I'd like to spend the next half hour this morning talking to you about the application of PET-CT in evaluating GYN malignancies. We're going to talk first about the normal variants and the benign variants in uptake in the female pelvis, and then we're going to talk about the applications in ovarian cancer. Just a note about CMS approval for these imaging in these tumors. Ovarian cancer is not yet CMS approved, but very soon, I think in January, there's going to be a tumor registry available so that CMS will reimburse you for these if you register clinical information and results with their tumor registry. Cervical carcinoma is approved by CMS for imaging. Of course, third-party payers will pay for imaging of a number of these tumors. And cervical carcinoma, we're going to talk about staging, we're going to talk about evaluation of recurrence, and a little bit about treatment planning. Endometrial carcinoma is lagging in terms of evaluation by PET-CT, but some of our gynecologic oncologists, the surgeons, tell us that they think that PET-CT should probably be used for evaluating lymph nodes in endometrial carcinoma instead of surgical staging. Again, just to remind you, we're talking about fluorodeoxyglucose, which is an analog of glucose. And the mechanism of uptake, which I think Dr. Ponzo reviewed with you yesterday, is just the overexpression of glucose transporters on the surface of tumor cells, also inflammatory cells, that will pick up 18-fluorine FDG, and it will be converted by hexokinase to FDG6 phosphate, and then because of the 2-deoxy configuration on the molecule, cannot be converted further. So it's trapped by these tumor cells. Just a quick review of technique. We ask our patients, our non-diabetic patients, to fast for 4 to 6 hours. We ask them to stay hydrated. Some people, when you're dealing with pelvic malignancies, will administer diuretics and catheterize the bladder. We have not been doing that yet. We do use dilute oral contrast ReadyCat, and we give somewhere between 10 and 20 millicuries of F18 FDG based on the patient weight. We ask our patients after injection to wait quietly for 45 to 60 minutes. We scan from the thighs up to the base of the skull, and we start at the thigh if we haven't catheterized the bladder because we want the bladder as empty as possible. And we do use IV contrast if there's no contraindication. We do breath holds through the chest. It gives us a little bit better look at the lungs, although it's not nearly the quality you get in a dedicated chest CT. And we look at both attenuation-corrected and non-attenuation-corrected images. We're just going to talk about uterine uptake. Normal uterine uptake can occur in menstruation and during ovulation. You should not see any uterine uptake in postmenopausal patients or amenorrheic patients. And you may see mild uptake in patients in the proliferative and secretory phase, and also in oligomenorrhea. Fibroids can have a variable appearance on PET. Here are 3 cases of benign fibroids. The first you'll see just has mild uniform uptake in the uterus. Here's another fibroid, again, the same issue. But here, in this patient, very heterogeneous and somewhat more intense uptake. Again, all benign. What about adnexal uptake? Well, you can see adnexal uptake during ovulation, in a corpus luteum cyst, in an endometrioma, in a dermoid cyst. However, in postmenopausal patients, if you see adnexal uptake, you've got to worry about malignancy, and it requires further evaluation. These are just some examples of benign adnexa. Here, you see a cyst with absolutely no uptake. Here, there's a rim of uptake around the cystic adnexa. And here, in this adnexa, a rim of uptake, and here a focal area of uptake that might actually have been bowel. And this is, of course, a problem with PET, but not so much a problem with PET-CT. So the positive predictive value of incidental adnexal uptake in FDG PET is about 25%. You can get false positives in inflammation, endometriomas, luteal cysts, cystadenomas, ovulation, and of course bowel can be confusing. But the negative predictive value is very high. I'm not advocating that this should be used as a screening tool for ovarian cancer. Early stage cystadenocarcinomas can be negative, and also tumors of low malignant potential may be negative. The evaluation of asymptomatic adnexal masses should not be done with FDG PET. They should be done with ultrasound or MRI, and I think that the literature supports this. In the evaluation of pelvic mass, there's been some look at FDG PET versus MRI, and these were in patients with suspected malignant adnexal masses. PET had a lower sensitivity than MRI, similar specificity, similar positive predictive value, and a lower negative predictive value. So again, it's not the modality of choice here. Well, let's move on to tumors. Ovarian carcinoma. Not for primary, but definitely for recurrent tumor. FDG uptake has been shown to correlate with the molecular biology of ovarian cancer, with GLUT1 expression, with markers of proliferation, and with histologic grade as assessed by architectural pattern, nuclear pleomorphism, and mitotic activity. False negatives may occur in mucinous epithelial tumors, just as they do with gastric carcinomas and pancreatic carcinomas. And they do occur, again, with borderline or low malignant potential tumors. PET and CT combined does improve ovarian carcinoma staging, but again, this is not always the way your surgical oncologists are going to want to go. In one study, staging improved or patients were upstaged from CT with PET. And one advantage may be that having the PET and having that additional information is going to help you avoid incomplete debulking, which of course is a standard in the treatment of ovarian cancer. This is a patient who actually presented with extensive abdominal pelvic disease, and you can see that here quite nicely. She had implants in her liver, she had iliac lymphadenopathy, she had bilateral inguinal lymphadenopathy, probably paraaortic here. She also had this, which was a cerebellar metastasis. What about in detecting recurrence? Well, the challenge is always detecting low volume disease in ovarian cancer. This was a patient who'd been treated with chemotherapy, and after about 6 months, her CA-125 was starting to rise, and she came to us in January, and she had this mild focus of uptake that we thought was probably bowel. But the surgical oncologists, because they're so intent on taking these out if they recur and they feel that they can achieve increased survival, were concerned about it. They brought her back in February, and now there's a little bit of soft tissue in there, and she has more intense uptake. Well, that was all well and good, except that as you can see here, she has other foci of uptake. She had this focus in the pelvis. This is just a close-up of that focus in the pelvis. Here's the CT. Nothing obvious here, but if you look at the fusion, she had a bony met in her acetabulum, and she does have bony metastases. So detection of recurrence is dependent on lesion size, and it's probably best used in correlation with clinical or serologic manifestations. It probably doesn't make sense to do women who are doing well without elevations of their markers. PET alone is going to be useful in disease that's greater than 1 centimeter. PET CT can probably move us down to 1/2 centimeter. In one small series of about, I think, 20 patients, the lymph node sensitivity for lymph node metastasis was 100% with PET CT, and for peritoneal masses greater than 1 centimeter, 50%, but when you got down to peritoneal micrometastases, the sensitivity was only about 13%. So we're probably never going to be quite as good as second look laparotomy and biopsy. But the per patient sensitivity was 73%. So if you're not looking to debulk, then, and you're looking to treat with chemotherapy or that's appropriate, then this may be helpful. The overall detection rate of PET alone, and there's not a lot of literature out there yet for PET CT combined, it's really based on PET, is about 83% if the disease is greater than a centimeter in patients with rising markers, and even when the CT is negative. The positive predictive value is high, 94%, and that's going to select your patients out for cytoreductive surgery. This is a patient with not a very subtle recurrence of her ovarian cancer. And she's obviously got retroperitoneal lymphadenopathy, liver implants, and a supraclavicular lymph node. But I show this case just because here's this very, very intense focus in the pelvis. And you can see that it fuses to a 7-millimeter lymph node. So it's not just size here, it's really also the metabolic activity of these tumors. And if they're metabolic enough, we're going to see the small ones also. Also, in assessing therapy response, here was a patient who'd been on chemotherapy, and you can see here, she has this focus in her pelvis that they were certainly willing to go after. And you can see the abnormality on the corresponding CT. But she also has Paraaortic lymphadenopathy, supraclavicular, and mediastinal lymphadenopathy. So she needs chemotherapy, not debulking. The last thing I'd like to talk about ovarian cancer is the use of PET in conjunction with or instead of second look laparotomy. I think personally I'd rather have a PET than a laparotomy. And in this study where they looked at the relapse rate over 5 years, which is generally 46% if it's negative, they looked at disease-free survival and time to progression. If the PET was negative, the disease-free survival was 40 months. If the second look laparotomy was negative, the disease-free survival was 48 months, not all that significantly different, and the time to progression was not significantly different. PET was 29 months, second look laparotomy 31 months. So it's very, very comparable. Okay, cervical carcinoma. Cervical carcinoma, we're very sensitive for uptake in cervical carcinoma. They behave very well as opposed to ovarian that sometimes the mucinous tumors, you don't see them. This is a patient with a not very subtle mass in her pelvis. It's picking up down here and probably some lymphadenopathy as well as hydroureter. These are just coronal, sagittal, and transaxial views of some of her tumor. And here you can see the large uptake in the tumor in the uterine corpus and extending from the cervix and the pelvic sidewall. And here on another cut, you can see the uptake in the left pelvic sidewall lymph nodes. But also, she has Paraaortic lymph nodes. And here, some more retroperitoneal disease. So the management, the staging of cervical carcinoma initially is very much dependent on the FIGO stage. And this is still a matter of physical examination and estimate of tumor volume. But we do know that tumor volume correlates very much with other manifestations of the disease, with lymphadenopathy, and of course it's very important to recognize whether there are lymph nodes present or not. Now, tumor volume can be assessed grossly with physical exam, but lymph nodes, especially Paraaortic lymph nodes, are not so easily assessed that way. And they're easily missed on laparotomy. It's important to distinguish localized from metastatic disease in patients with cervical carcinoma because we're going to select our patients for radiation therapy versus radiation therapy and chemotherapy combined. The sensitivity of PET for lymph nodes as compared to CT MRI in one series of patients that came out of Penn was 76. It was better than the CT-MRI, sensitivity of 76%. Routine PET, which is usually performed after about 45, 60 minutes, was about 86%. But if they waited 3 hours, they had 100% sensitivity. This was not a large series of patients, but the take-home message here is the longer you can keep your patients there and the longer you can wait for uptake, the more sensitive you're going to be. In that series of patients, when there was a negative CT, the sensitivity of PET was 86%, the specificity was 94%. And if you look at sensitivity of PET versus CT by lymph node location, you'll see that in general, PET is more sensitive. Certainly more sensitive in pelvic lymph nodes, more sensitive in paraaortic lymph nodes, and will pick up supraclavicular lymph nodes when all you're doing is abdominal pelvic CT. What about prognosis and paraaortic lymph nodes and using PET to assess that? Well, in this series, they looked at 2-year progression-free survival. If the CT and the PET were both negative, there was a 64% progression-free survival at 2 years. If the PET was positive, it went down to 18%. And if both PET and CT were positive, it moved a little bit down to 14%. So paraaortic lymph nodes on PET are probably the most prognostic indicator for progression-free survival. The bottom line with lymph nodes and cervical carcinoma and PET, PET upstages patients over CT for paraaortic lymph nodes. You're going to get more lymph nodes, advanced lymph node staging with PET, and that's going to tell you you've got a decreased overall survival, and those are the patients that you need to be more aggressive with in terms of adding chemotherapy to your regimen. Okay, let's talk a little bit about tumor volume. MRI seems to be, if you're going to go beyond physical exam for assessing tumor volume, MRI seems to be the modality of choice for doing that. And it's probably better for predicting corpus uterine uptake. It's certainly better than predicting it than FDG PET. However, FDG PET is going to be better for predicting lymph node involvement. And one interesting finding in this series that compared MRI and FDG PET was that if there was corpus uterine involvement on MRI, there was a 75% likelihood of positive lymph nodes on PET. So those are definitely patients with large tumor volumes that need to go on to PET. What's the clinical significance of tumor volume? Well, we know it correlates with clinical stage and lymph node involvement. Larger volumes have decreased progression-free survival and shorter overall survivals. And the correlation with lymph node staging, although it tends to be higher, is not definite. Some people are starting to begin to try to determine tumor volumes with FDG PET, and this is mostly related to radiation treatment planning. But what they've been able to do is develop a very close identity between CT measurements and PET measurements. And they do this by thresholding the PET uptake at 40% of maximum intensity. They have to manually eliminate bladder activity, and then they just sum the voxels of activity. If you're thinking about doing RT planning with PET CT, you use the PET CT to establish body outlines so that you can then fuse your PET CT with your planning CT. You want to use a planning bed so that there's some analogy and your pelvic tilt is going to be similar. You want to minimize bladder activity by hydrating the patient using diuretics and bladder catheterization. Some people are talking about using an applicator to fix the position of the pelvic organs. Again, you're going to threshold. But the question here is, since we're talking about modulated radiation therapy, for this is how do you account for changes in tumor volume? One of the problems with radiation therapy from our point of view is that you get increased uptake from the inflammation. So once you've started to irradiate, it may be difficult to determine volume from PET. This is a patient who's been treated for cervical carcinoma. The uptake here in the neck is just, and along the spine is just brown fat, but she does have focal uptake here. And you can see here in the right pelvic sidewall and here in the retroperitoneal region, focal uptake. Well, how does FDG PET CT do for monitoring recurrences? In the early studies, and again, just PET alone, the sensitivity was 86%, specificity 87%. The positive predictive value was 86, and the negative predictive value was 87, so pretty decently. The false positives occur with radiation colitis and with rectovaginal fistulas, which are all complications of the treatment. But in these cases, I think PET CT is going to help enormously with these false positives. For looking at local recurrence, very high specificity. Sensitivity is going to be more difficult, again, because of confounding factors of treatment. And very good for distant recurrence. Again, I think that's going to be PET's strength here. And high specificity. So in these patients, if you can get detection of disease early or in asymptomatic patients, with treatment you can prolong overall survival. And I think that this makes a good case for using PET in these patients. In a series looking at algorithms for using PET and cost effectiveness, they found that PET was most useful in good prognosis patients. In moderate prognosis patients, it was useful for changing treatment from curative to palliative. And in the poor prognosis patients, it may not make a difference because you're going to do palliative treatment anyway. Let's move on to endometrial carcinoma. This is a patient who has a history of breast cancer that we evaluated because her markers were going up a little bit. And what we see is this intense uptake in the uterus, which turned out to be an endometrial carcinoma. Well, we know we can see endometrial uptake, and it's not always impressive. But in a recent series, it's been suggested that if the SUV is greater than 7, and this is not a huge series, it's not like the solitary pulmonary nodules in lung cancer, but in this series, all of the patients who had SUVs greater than 7 in their uterus had cancer. So it bears further evaluation, if nothing else. This is not the way to screen for endometrial carcinoma. Mostly these are going to be incidental findings. However, it may be useful to do staging of endometrial carcinoma with PET. This is probably not all that interesting, the sensitivity for the primary, and this is a somewhat disappointing sensitivity for pelvic and Paraaortic lymph nodes. Again, this is a 2002 paper that was done without IV contrast and without a CT. But they did have a very high specificity on PET. This is a patient who had had surgery and had also had radiation therapy for her endometrial carcinoma, and she presented with this hydroureter. On her fused images, you can see the intense uptake of the hydroureter and the bladder, but there's also this area of increased uptake here in the left pelvis. On the corresponding PET alone images, you can see this rim of increased uptake with just an area of irregular uptake just sitting above it. And here's just a 3-view look at that. And again, you can see this rim around a hypometabolic area with an area of greater activity above. And if you look at the CT, well, she had a lymphocele which was inflamed, probably from the radiation, but also here she had soft tissue just sitting above that lymphocele that on biopsy turned out to be recurrent tumor. Well, endometrial carcinoma spreads hematogenously, and as you can see, we can be hampered by post-radiation and surgical changes. The tumor marker is probably the mainstay of following these patients. But it's important to know that metabolic imaging recurrence may precede CT changes by months. Here's another patient with a history of endometrial carcinoma. She's got some bowel uptake here, but she also has, as you can see, multiple foci in the retroperitoneum and something sitting here in the pelvis. And on the images of the pelvis, you can see that she's got a recurrence at the cuff, and she has multiple retroperitoneal lymph nodes, and also a subclavian lymph node. So in this series, PET had a 96% sensitivity for recurrence, moderate specificity 78%, but a very good positive predictive value. They detected unsuspected disease in 12% of patients. They affected an alteration in treatment in 35%. Again, even with PET-CT and even with trying to optimize your reconstruction algorithms and using a breath hold, PET is never going to be as good as dedicated chest CT for evaluating small pulmonary nodules. So the role of PET in recurrence in endometrial carcinoma after therapy has been suggested that with a CA-125 that's positive, you want to get PET. If it's negative, you repeat it every 3 to 4 months after treatment for 1 year. If it remains negative, you repeat every 2 months for 2 to 5 years. And then after 5 years on a patient-per-patient basis, and if and when it becomes positive, that's when you throw PET into the algorithm. So just in summary, PET is not a screening tool, but you're going to find incidental findings on your patients, your women being screened or evaluated for other tumors. And so you need to be aware of what those findings may mean, either in the ovary or the uterus. But for ovarian carcinoma, it's going to be extremely powerful in detecting recurrence and for assessing responses to therapy. In cervical carcinoma, it does have a role in staging, in selecting therapy, radiation therapy versus chemo and radiation combined. It may have a role in radiation treatment planning. This is being done very actively at Mallinckrodt right now, and it certainly has a role for monitoring therapy. In endometrial carcinoma, it may actually play a role in staging, and I think the PET-CT data is not out there on endometrial cancer, and this may make it a much more powerful tool, and in detecting recurrence in conjunction with tumor markers.